In this video, we will talk about the DSM, the ICD, diagnosis, pros and cons, and prevalence of psychological disorders. In a previous video, we talked about three components of mental health disorders. So the first thing is being deviant. In other words, behavior that is deviating from the norm within the society or the norm for that person. Then we talked about dysfunction. This is where a person is not performing at an appropriate level or has something that they're not able to do that they were able to do before, or maybe if they're a child, they're not performing at the level which they should be. So that would be a dysfunction. And the last part is distress. Usually the person with the mental health disorder or mental illness will have distress, and that's usually what drives them into getting some help for the situation, is that they're feeling significant distress. Remember, we also have danger to consider also if that person is a danger to themselves or others. This is another thing that is considered. And that is one way to kind of look at all of these things together to look and see if this person may be suffering from a mental disorder. According to the American Psychological Association, their definitions are pretty close to the same thing, just a little bit different. A psychological disorder is a condition that consists of the following: significant disturbances in thoughts, feelings, and behaviors. These things are outside of cultural norms, and disturbances reflect some kind of biological, psychological, or developmental dysfunction. The disturbances lead to significant distress or disability in one's life. For example, difficulty performing appropriate and expected roles. So maybe you're not able to do the job you're supposed to do at work anymore. You're not at the grade level you're supposed to be in school. So, these are things that are considered when making a diagnosis. Despite the many existing definitions, there is no universal agreement on where the boundary between disordered and not disordered is. So in other words, the line between abnormal and normal behavior, there's no clear-cut line. Sorry about the coughing. I'm still pretty sick. They're going to do a CT on my lungs tomorrow, so hopefully we can get this all figured out. Anyway, onward we go. In order to diagnose a mental disorder, one of the key books that is used is called the Diagnostic and Statistical Manual of Mental Disorders. This particular book is kind of what is used so that if I am diagnosing a client here in California and that person moves to the East Coast and that person is looking, and their new psychiatrist or whoever is looking at their health records, they can look at the codes from this DSM and say, oh, this person has been diagnosed with anxiety or something like that. Whatever the diagnosis is, they can look at the specific code, and the code will tell them the main diagnosis and the subcategories that are appropriate for that person's diagnosis, and they will pretty much be able to get a good, clear picture of what that client is experiencing based on that. So it helps with research. It helps with kind of communication between different mental health professionals. So a diagnosis is, whoops, okay, I'm being terrorized by my cats, whatever. Okay, it's like 12:30, 1 o'clock, something like that. Anyway, diagnosis is appropriately identifying and labeling a set of defined symptoms. It requires classification systems that organize psychological disorders systematically. So in the DSM, what you'll see is a set of criteria that somebody would have to meet in order to get that diagnosis. So let's say there's 9 different behaviors or thought patterns or whatever that are seen for diagnosis of a particular disorder, and you have to have 5 of those present, 5 of the 9 present in order to be diagnosed with the disorder? Well, if I know somebody that I could say, oh my gosh, I can check off, 5 of these boxes or 6 of these boxes. Oh man, this person could be diagnosed with whatever this disorder is. However, if this person is not distressed, is not having a dysfunction, and is not, particularly deviating from the norm, then even though they have certain thought patterns and behaviors that may be present in that disorder, that would not be you would not be appropriate to diagnose that person. So you basically have to have all of the components in place in order to do a diagnosis. Now the DSM, the Diagnostic and Statistical Manual of Mental Disorders, is what we call the DSM. We are currently on DSM-5, and every once in a while it is updated, and there's always debates as to how we should categorize things, and things are changed. Diagnostic categories are changed, and this oftentimes kind of goes with whatever the trends are. Like in the earlier chapters, we talked about these different perspectives on psychology. So kind of whatever the prevailing perspective is going to have a major influence on the DSM. And if you take an abnormal psychology class, they get into more detail about this. And like in my class, I go into more detail about the pros and cons of the latest changes in the DSM, the changes between the DSM-4 and the DSM-5. Excuse me. So the DSM is published by the American Psychiatric Association. It was first published in 1952, and it's gone through numerous revisions. Like I said, we are on DSM-5 right now. As things change in our culture, as things that are maybe not accepted at one time and are now accepted, for example, wearing blue jeans. In the 50s, if you wore blue jeans and like a t-shirt, you're a hoodlum. You are not like mainstream. You are deviating from the norm. So, that was something that was considered, people look at you sideways when you wore jeans. Nowadays, everyone wears jeans, so it is a socially acceptable thing. Same thing with homosexuality. Now, as we've learned more about homosexuality and how, people who are in same-sex relationships really aren't very different than people in heterosexual relationships. So, as our culture has become more broad-minded and less strictly based on like maybe conservative values are not as strongly influenced within the society, things change. So, for example, in 1973, homosexuality as a disorder was removed. Now, in the DSM, we do have different sexual disorders in there. And the sexual disorders, once again, some people say, oh, this is a disorder, this isn't. And usually you have to have those components of distress, dysfunction, and deviance in order to get that diagnosis. So somebody may, have some funky stuff they like to do, but as long as they're not hurting anybody, it's not hurting them, whatever, we're not going to call that a disorder. And we won't get into that in this class, but in abnormal, you do go into those things. The DSM-5 is the classification system used by most mental health professionals. Now, interestingly, when I worked for the county, we had to do diagnoses using the DSM-5 for the county. However, for Medi-Cal payment, we had to do a diagnosis using the ICD-10, which we'll talk about on another slide, which is the international system that is used worldwide. Let's see. Okay, categorizes. So the important thing about the DSM is it categorizes and describes each disorder. For example, you may have like depression, or have a depression, and under depression you can have all of these different categories. You can have with psychotic features, with all sorts of different subcategories. Sorry, my brain isn't working too good because I'm sick, but basically it breaks it all down, and you select a code based on what most closely describes what you're seeing in the client. And then, like what we had to do, which was real pain in the neck, is diagnose with the DSM-5 and then get the closest diagnosis we can with the ICD-10 10, which is now ICD-11. But what can I say? I'm retired. Okay. So one of the diagnostic the disorder features that you see is there's like an overview of disorder, like there's an overview of depressive disorders, and then it would get into specific diagnostic criteria for each specific depressive disorder, okay, or anxiety disorder, or whatever category it's in. Prevalence would be percentage of population thought to be affected or afflicted. So we'll look at a little chart later in the video that talks about prevalence. And I think these numbers are a little bit old. I didn't have time to pull up new numbers for you guys, but we'll look at prevalence. That's like what percentage of the population has schizophrenia. Well, usually that's about 1%. And we'll be looking at numbers like that. Risk factors. We'll be looking at risk factors for these particular disorders. We know that adverse childhood experiences are things that predispose people to having a higher risk for mental health disorders. And the DSM also provides information about comorbidity, which is the co-occurrence of two disorders. Most people that are diagnosed with a mental disorder, they are actually usually have more than one thing. For example, if you have depression, you are probably really bummed out. You're having trouble sleeping. Maybe you're not wanting to go to your social events. Maybe you're missing out on things because your depression isn't allowing you to get out of bed and get a shower and get ready and go to interact with people. And your depression is keeping you from doing that. Well, after some time, you might also develop some anxiety because now you're feeling anxious because your relationship with your friends are strained. You're anxious about the days of work you've missed, and you may end up having an anxiety disorder as well, because anxiety and depression go hand in hand. Just like if you're starting with having a whole bunch of anxiety. So let's say that you have social anxiety and you really are struggling to go meet with your friends and have lunch or do social things at work or even be in social situations at work. Well, if this starts giving you difficulty to where you start avoiding those things, after a period of time, you're going to isolate yourself, and that isolation can actually contribute to developing depression as well. So anyway, comorbidity means that you have more than one mental disorder at the same time. I just kind of accidentally left this slide in. Classification of psychological disorders. This is for the DSM-5, the accepted standard for classifying psychological disorders, growing body of research on DSM's reliability and validity. So reliability and validity, meaning how reliable are the diagnostic criteria and how valid are these criteria? Why are we including these criteria in the diagnosis? And so those are things that we really try to carefully look at. Criticisms of the diagnosis of psychological disorders. So in order to be able to get help with your mental health disorder, you end up needing a diagnosis of some sort. And the reason you need a diagnosis is so that can be submitted to insurance and insurance can pay for your visit. Now, without a diagnosis, you don't have a code, so you don't get to get paid. I mean, the therapist is not going to get paid. So interestingly, let's say that you're going into talk to somebody, you're feeling depressed or whatever, and you get in there and, you start talking to them and maybe they give you a diagnosis of adjustment disorder because that's kind of the mildest thing. Maybe you're just having these troubles and anxiety and depression and all this just because of circumstances that have changed and you're having difficulty adjusting to these circumstances. And so maybe they're giving you that so that you can just get started with your therapy. Later, maybe this is going to change to maybe they're going to find out, oh my goodness, we think you have bipolar disorder. And then later on, it's like, oh my goodness, you have borderline personality disorder. So these diagnoses can change over time. And once you have a diagnosis, the positive thing is that, okay, that gives us some criteria to work with, and we can look at what treatments have been successful for these disorders. Yet at the same time, there are stigmas attached to these different disorders also. And when you take abnormal, probably go into a little bit more detail about the stigmas related to mental disorders. Now let's talk a little bit about the ICD, the International Classification of Diseases. So the ICD is published by the World Health Organization, and this is the book basically used all around the world, except for here. We're like the only ones that really use the DSM. Everyone else uses the International Classification of Diseases. Now, this ICD isn't just for mental health or mental disorders. There's a subcategory, a sub-portion of the book that specifically focuses in on mental disorders. The ICD, if you have kidney disease or anything else like that, it's going to be in the ICD also. So the classification and criteria for specific disorders are similar to the DSM, but there are some differences. And basically, if you have to use both, you just get as close as you can. It's used to examine general health of populations and monitor prevalence of disease, health problems internationally. So the focus on the ICD's focus is basically on general health population, kind of looking at everybody's health, and that's what's really it's focused on. Whereas the DSM is looking a lot more at research as well. The ICD is more clinical, the DSM is more applicable for research. And the DSM, it says here includes more explicit disorder criteria as well as extensive explanatory text. To me, part of this may be due to our insurance systems because we're the only country that has these types of insurance systems. So, this complicated. So that may have something to do with it as well. A lot of our therapists these days do not take insurance. They're a cash only because they get so tired of being wrapped up in the paperwork and red tape of trying to get people approved through Medi-Cal and places like that. And like Medi-Cal will pay a much lower rate and will not cover as many visits. So it's hard to do your job and be able to be successful with that person if the insurance isn't going to pay for you to do your job properly. So you'll find that a lot of our therapists these days are cash only. I already mentioned that there are some really good benefits of using these documents or these DSM-5 or ICD-10 for diagnostic reasons, especially the DSM-5 within the United States, since that's what we use. Some of the benefits are it provides a descriptive system. I already talked about that. A therapist in California is going to be able to look at the diagnostic codes and stuff, and the same in Connecticut, they're going to look at it and they're going to be like, oh, I can expect that this client is experiencing these things based on this diagnosis. So it allows communication between mental health professionals and theoretical approaches, in other words, for research. It enables researchers to explore the causes of problems and provides a shorthand throughout which professionals can describe the behaviors that tend to occur together in an individual. Now, the DSM is not perfect, and it is something that, changes over time. We try to make it better as we learn more. Now, interestingly, there was research done back in the early 70s by David Rosenhan, and basically what he did was he faked mental health, a mental illness, basically that he was hearing voices, and got himself put into a mental hospital. And he basically was saying he recruited people and he had these other people get taken in to the mental hospital, giving the same criteria of what voices they were hearing to specific things. And they found that when the people were in the hospital, as soon as they were admitted to the hospital, they quit showing any symptoms. So in other words, it was just, oh yeah, I'm hearing these voices say, I think it was dull, thud, and some other word. Anyway, so basically what he was saying was that, when you got in there, even though you never showed any more symptoms, they medicated you, they treated you poorly, you were very depersonalized. It was a very, very negative experience. The other thing that Rosenhan did was he told the doctors in the hospital there that he was going to send some pseudo patients in other words, people faking their symptoms into the mental hospital, and that they would have to identify who the pseudo patients were. Well, they came up with like 26 pseudo patients when actually he didn't send any. The outcomes of his study, basically was a lot of mental hospitals were closed down. They closed a lot of mental health hospitals due to the behavior and the way people were treated and everything like that. So it was really bad. But then later on, it comes to find out that actually Rosenhan faked a lot of his stuff. One of the guys, it was only like him and two other guys that got admitted, and supposedly maybe three, but two or three other people. And one guy had a really positive experience. When he went in there, everybody was kind, and it was a very healing environment, a very good environment, whereas Rosenhan's experience was very, very negative. So he just kind of left out the stuff that didn't agree with his thesis. So that's, obviously bad science, and, he's been called out on this, but it wasn't until years later that people found out that he kind of lied and fudged a bunch of stuff. But anyway, even, before all that was found out, he had a huge impact on the DSM, because all of a sudden, mental institutions were getting, oh my gosh, we got to do something, we got to change, because, all this that we're seeing. And the DSM people were scrambling and trying to come up with better diagnostic criteria, because what they found out, what David Rosenhan was saying was that these doctors can't tell people who have mental illness from those who do not have a mental illness or a psychological disorder. So basically, once they went in there and said they had these symptoms, and then there were no symptoms after that, they didn't say, oh, you don't have a mental disorder. They just said, oh, you have schizophrenia in remission. So in other words, they didn't catch the diagnosis. So this made everybody panic and try to come up with better criteria for diagnosing mental disorders. And like I said, something good did come of it, but the study was basically discredited. Anyway, let's see. Yeah, after initial diagnosis, mental health professionals overlook other diagnostic possibilities. And that is something that can often happen. People can get into a rut. That's why, like, if you're seeing somebody, it's really good to just get your impression of them, your own impression of them. There's a stigma of labeling. Individuals may need formal diagnosis for treatment, but the label may stigmatize the individual in other ways. And we already talked about that. All right, so that's it. We're going to go ahead and move into some other stuff.